VIH y en el año 2022 presentó el tema actualizaciones en evaluación renal para proveedores que atienden a pacientes con VIH. Démosle una cordial bienvenida. Gracias.
Thank you very much for that nice introduction. It's a pleasure to be here with you all remotely. I'm going to be providing an update on kidney disease evaluation and management among people with HIV. And relevant disclosures to this talk include honorarium from the American Academy of HIV Medicine, as well as royalties from UpToDate for authorship on a HIVEN chapter. So I've outlined 3 learning objectives. The first that we'll discuss is assessment of kidney function using GFR estimating equations among people with HIV. So I'm going to start with a clinical case that I think is a common scenario that we often encounter in clinical practice. This was a patient that was referred to me for worsening kidney function. He is a 41-year-old African-American male with well-controlled HIV who was referred by his primary care doctor for a noted rise in his serum creatinine level. He had no other medical problems and was very active. He reported working out at the gym frequently, and his physical exam was unremarkable with his weight and BMI both noted. Labs over the last few months showed an increase in his serum creatinine from 1.2 to approximately 1.6. This corresponded to a decrease in his estimated GFR from 74 to 54. And then in looking at his creatinine clearance, which we still use for drug dosing of medications, there was also a drop in his creatinine clearance from 84 to 65. So the question was, does he have chronic kidney disease? And we'll come back and discuss more details about this case, but I first want to discuss estimation of kidney function in people with HIV. In the United States, drug dosing guidelines are still based on creatinine clearance from the Cockcroft-Gault equation, but we know that creatinine-based estimating GFR equations are what we generally use to estimate kidney function. And the CKD-EPI equation is generally the most accurate and what is recommended to estimate GFR. The advantage of using creatinine as a biomarker of kidney function is that it's widely available. However, some disadvantages to be aware of are that it's affected by muscle mass, where it may not perform as well at the extremes. So the creatinine may be higher and underestimate GFR in younger muscular patients, while in older frail patients, creatinine may be lower, and this may result in an overestimation of their true GFR. And then it's also important to note other medications that they may be taking that can also affect creatinine level. For instance, there are certain antiretroviral agents that inhibit tubular secretion of creatinine, which can lead to a rise without actually causing a true change in GFR. So if we go back to his case, we can see that his antiretroviral therapy regimen was recently switched from a non-nucleoside reverse transcriptase inhibitor-based regimen to an integrase inhibitor-based regimen. So now he's taking dolutegravir lamivudine, and this switch occurred over the course of the last couple months. And then it's also always important to ask about protein supplements and creatine supplementation, especially in young men. It turned out with this patient, he also reported he was trying to build muscle and was taking protein supplements when he went to the gym. My experience has been that many young patients with HIV will use these supplements to help build muscle, and these also have the potential to affect creatinine levels. So it's important to remember that although creatinine is the most common biomarker that we use to estimate GFR, it's not a perfect marker of kidney function. 90% of it is filtered in the glomerulus, but 10% has to be secreted through a transporter in the proximal tubule. And there are numerous HIV medications that can block the excretion of creatinine in the urine. Medications that inhibit this OCT2 transporter on the basolateral side of the proximal tubule include the integrase inhibitors like dolutegravir, and then the non-nucleoside reverse transcriptase inhibitor also has an effect on this transporter, rilpivirine. Trimethoprim also has an effect here. And then there are medications on the other side, on the apical side of the proximal tubule that also have an effect on inhibition of tubular secretion of creatinine. These include the pharmacoenhancers cobicistat, ritonavir, which are often used to boost drug levels of protease inhibitors, and then rilpivirine and trimethoprim also have an effect here. So the effect of dolutegravir on creatinine levels is illustrated by this small study that looked at 44 people with HIV that was well controlled. In this study, the majority of patients were switched to dolutegravir, but several were initiated on it, and they looked at pre-post assessment of creatinine as well as cystatin C-GFR. And you can see over here on the right, there was about an 8 ml per minute decline in the creatinine-based estimated GFR level after initiating dolutegravir, whereas there was no change with a cystatin C-based eGFR. So changes in creatinine will typically occur within the first 4 weeks of starting or switching to an integrase inhibitor, and they subsequently plateau after that point. So it's generally good to check a creatinine at the time of the switch and then 4 weeks later. It wouldn't be typical for the creatinine to continue to rise after that point. It's important to note that this change in creatinine can occur with any integrase inhibitor, so it's not unique to just dolutegravir. It can occur with bictegravir as well as others. The expected change is generally small, about a 0.1 to 0.2 milligram per deciliter increase in creatinine, although in patients with pre-existing chronic kidney disease, you may see a bigger change. This may correspond to a 5 ml per minute decline in GFR or even up to a 20 ml per minute decline in GFR. And it can be challenging to differentiate this from kidney toxicity related to other medications, particularly patients who may be taking tenofovir. Some clues, though, that this is a benign change include the absence of proteinuria, tubular toxicity, or structural damage. GFR can also be estimated, though, using cystatin C. And cystatin C is a different biomarker that's produced by all nucleated cells, and it's completely cleared by glomerular filtration. Some of the advantages of using cystatin C to estimate GFR are that it's less affected by extremes of muscle mass or age. And the levels are also not affected by antiretroviral medications. However, a disadvantage of using cystatin C is that it can be just elevated due to systemic inflammation. And it's currently not recommended alone to estimate GFR among people with HIV. There are combined equations using both creatinine and cystatin C estimated GFR that may be more accurate than either equation alone among people with HIV who are receiving stable antiretroviral therapy. And then recent changes have also occurred in estimating GFR equations, and this includes the removal of race. An adjustment for race in estimating GFR was previously justified on the basis that the race coefficient improved the equation's accuracy and precision in predicting measured GFR. This systematically assigned higher kidney function for all Black individuals, and through systematic bias led to under-recognition of chronic kidney disease in individuals where the prevalence of chronic kidney disease is high and progression is rapid. So in 2021, the CKD-EPI Consortium put forth a new equation that's been widely adopted by our nephrology professional organizations to estimate GFR without race. This is data from the NA Accord, North American cohort of people with HIV, where they looked at this equation compared to the old equation that used race. In this study, there were more than 69,000 participants, almost half of which were self-reported Black race. And what they found was 16% using the new equation were reclassified to a higher CKD stage. And they also found that the reclassified Black individuals had a higher prevalence of CKD risk factors than other individuals who were not reclassified, demonstrating that the old equation was masking CKD in these individuals. So going back to our case of our young African-American man with an elevated creatinine, we can compare all of these equations. So in this case, we obtained a cystatin C level, and we looked at the CKD-EPI creatinine equation alone with an estimated GFR of 54. We looked at the combined equation without the race variable, where his GFR was 77. And then we can also look at the cystatin C equation alone, where his estimated GFR was 99. So in terms of workup, a urinalysis was sent, which was normal. We also quantified how much proteinuria he had, which was also normal. And given this large discrepancy between the cystatin C GFR that was significantly higher compared to the creatinine GFR, with that change really occurring after starting an integrase inhibitor, the conclusion was this elevated creatinine was likely due to the dolutegravir and maybe the protein supplements he was taking, and he had no evidence of chronic kidney disease. So practical points in estimating kidney function in people with HIV are to recognize that there are medications that can affect creatinine levels, especially when you're thinking about starting or switching ART medications. I think it may be helpful to obtain a cystatin C GFR before starting or switching ART. And it's important to remember that it's not uncommon to see a 5 to 20 ml per minute decrease in creatinine-based GFR after starting dolutegravir or other medications that may have an effect on creatinine. So next, I'm going to review some of the epidemiology and causes of chronic kidney disease in the modern era of antiretroviral therapy. I'm going to start with another case of mine. This was a 33-year-old African-American male who was sent to our emergency room by his primary care provider due to severe kidney failure seen on labs. He was recently treated for multiple sexually transmitted infections, and in the emergency room, an HIV antibody test was sent, which was positive. At that time, his CD4 count was 50, and he had an unsuppressed HIV viral load. His creatinine level was 7. He also had significant lower extremity edema and a serum albumin of 2.6, and he had nephrotic range proteinuria of more than 7,000 milligrams on quantification. An ultrasound was also done of his kidneys, which showed that his kidneys were enlarged 15 to 16 centimeters in length. Normal would be about 10 centimeters. So this was about a 1.5-fold increase. And on ultrasound, in the renal cortex area, as shown here, you can see this gray appearance, which represents hyperechogenicity. So all of these are very characteristic classic features of HIV-associated nephropathy or HIVAN. So HIVAN is really the classic HIV-related kidney disease that we think about. It's seen in advanced HIV, or it can be the presenting feature of newly diagnosed HIV infections, such as this case. Risk factors for HIVAN include having a low CD4 count and an unsuppressed viral load. And it's characterized by a progressive kidney failure that can rapidly progress to end-stage renal disease requiring dialysis within weeks to months without treatment. However, we know that treatment with ART is very effective in slowing the progression of HIVAN. Proteinuria is typically nephrotic range, as was in this case. And then other urinalysis findings are typically nonspecific. Other than proteinuria, patients typically don't have evidence of hematuria or other cellular casts. And on imaging, you may see enlarged hyperechogenic kidneys, as in this case. HIVAN or HIV infects both kidney tubular epithelial cells as well as podocytes. So HIVAN can have an effect on both causing glomerular disease as well as significant tubular interstitial injury. So these are just a few histologic pictures of what HIVAN looks like on kidney biopsy. So some of the pathologic features include this parietal cell hypertrophy and hyperplasia, which ultimately causes collapse of the glomerular tuft. So this is known as collapsing glomerulopathy. In the middle picture, this is showing acute tubular injury on light microscopy, and then these characteristic microcystic tubules that are seen are a hallmark feature of HIVAN. And then on the far left, where the arrows are pointing, these are called tubulo-reticular inclusions. They're found inside endothelial cells, and they're also a sign of increased interferon release, and they're seen with HIV, as well as COVID and other diseases that are marked by high levels of systemic inflammation. So early in the HIV epidemic, numerous important observations were made that HIVAN occurred predominantly in individuals of African ancestry. And in the last decade, our understanding of the disproportionate burden of HIVAN and chronic kidney disease seen in people with HIV of African ancestry has been through the discovery of genetic variants in the APOL1 gene, which is expressed in kidney podocytes. And the story of APOL1 is really similar to the story of sickle cell anemia, where we know that malaria is endemic in certain parts of the world, and mutations in hemoglobin S and hemoglobin C occurred as a survival advantage. So if you were heterozygous for one of these mutations, through selective pressure, this offered protection against malaria. But if you were homozygous, this resulted in sickle cell anemia. Similarly, in areas of Africa where trypanosomiasis, the disease that causes African sleeping sickness, is endemic, there are mutations that occurred in this gene called APOL1, called G1 and G2 polymorphisms. This also conferred a survival advantage if you were heterozygous for one of these risk alleles, but then you had a normal allele. But if you had two risk alleles, then you're at increased risk of developing certain types of kidney diseases. And specifically, HIVAN is one of the kidney diseases that's most strongly associated with these risk variants. And the disease-causing APOL1 genetic variants rose in humans in sub-Saharan Africa several thousand years ago, and the frequency of these variants rose quickly in African populations because of this enhanced protection against trypanosomes causing African sleeping sickness. The highest prevalence of the APOL1 high-risk genotypes is seen in West Africa, but it's also found throughout sub-Saharan Africa and among individuals in the Americas with African ancestry. With considerable, and it is also noted in Hispanic populations with recent African ancestry, considerably higher frequencies in the Caribbean populations compared to Mexico or Central America. So the prevalence in West Africa is about 30 to 40% of individuals have a high-risk APOL1 genotype, whereas in the Americas, it's about 10 to 15%. And as I mentioned before, APOL1 risk variants strongly contribute to the development of HIVAN. Having a high-risk genotype confers a 29 to 89-fold increased risk of HIVAN based off of case control studies. And about 70% of HIVAN is associated with a high-risk APOL1 genotype. And in certain populations in Africa, it's estimated that the lifetime risk of developing HIVAN without antiretroviral therapy among people with HIV is 50%. Now, HIVAN is the only known APOL1-related kidney disease that's treatable. It was a leading cause of end-stage renal disease among young African-American men in the US, but in the mid-1990s, as shown here, with widespread availability of antiretroviral therapy, you can see a sharp plateauing in the incidence of end-stage kidney disease due to HIVAN. And HIVAN is uncommon in people with HIV who are receiving ART and who are virally suppressed. This is illustrated by a US study of men with HIV who had APOL1 genotyping data. The study showed that unsuppressed people with HIV with a high-risk APOL1 genotype experience accelerated loss of GFR compared to those with a low-risk genotype. Whereas those who are able to achieve viral suppression, who have a high-risk APOL1 genotype, have a similar decline in GFR compared to those with a low-risk genotype. And these findings were independent of age, comorbid conditions, baseline GFR, ancestry, as well as other HIV-related factors. And I point this out because this year actually marks the 10th year since the World Health Organization recommended that all people with HIV be treated with antiretroviral therapy, irrespective of CD4 count. But despite this recommendation, a significant proportion remain untreated across the world. In looking at the WHO statistics from Mexico, 61% of people with HIV who are diagnosed are receiving ART, and 54% are virally suppressed. And our data in the United States are very similar to this. And kidney disease, specifically HIVAN, is an indication to start ART. So what does HIVAN look like in 2023? Classic HIVAN is still seen in treatment-naive people with HIV or those who aren't adherent to ART. But there's been a rise in the prevalence of non-collapsing FSGS, which is a less aggressive form of kidney disease in the ART era. This has been observed in people with HIV who are receiving treatment, who have more well-controlled HIV, so a CD4 count above 200 with an undetectable HIV viral load. And this non-collapsing variant of FSGS has been hypothesized but not proven to represent partially treated HIVAN. In the modern era, though, the landscape of kidney pathologies has changed significantly. So the prevalence of chronic kidney disease is about twofold higher in people with HIV compared to people without HIV. And as I mentioned before, HIVAN is less common, but there's been an increased prevalence of focal segmental glomerular sclerosis. However, there are other types of glomerular diseases known as immune complex glomerular diseases, as well as traditional CKD risk factors in our aging population, including diabetes and hypertension, as well as certain medications that also may be associated with kidney toxicity. So immune complex glomerular diseases represent a heterogeneous spectrum of glomerular diseases, including things like IgA nephropathy, lupus-like glomerular nephritis, and membranous nephropathy. And the causal relationship with these diseases to HIV is less clear. They haven't been shown to be associated with APOL1 genetic risk factors, and they're also often seen in individuals with well-controlled HIV and viral suppression. They've been hypothesized to be due to a host immune response to HIV, but there aren't any good animal models to study these diseases. And the kidney disease improving global outcomes classification replaced the term GEVIHS with immune complex glomerular disease in the setting of HIV, since it's uncertain what the relationship is between these diseases with HIV. With an increasing life expectancy, more than 50% of people with HIV in the US are now over the age of 50. And traditional CKD risk factors have become very common causes of chronic kidney disease. These include things like diabetes, hypertension, as well as hepatitis C co-infection, which is present in about 30% of people with HIV. And some of these diseases, specifically diabetes, has been shown to have an additive or synergistic effect on CKD progression, both in animal models as well as in clinical studies. And the largest contemporary study of kidney biopsy findings in people with HIV in the modern era comes from the United States, from a New York City hospital. So this was a cross-sectional study over an 8-year period of time that reviewed all kidney biopsies referred across 13 states in the US, from which people with HIV accounted for 1.6% of all of the biopsies. The mean age was 53 years, 2/3 were male. About 60% were self-reported Black race, 1/4 were white, and 17% were Hispanic. And as you can see, the majority were on antiretroviral therapy or receiving treatment. The 3 most common comorbidities included hypertension, diabetes, as well as hepatitis C co-infection. And then on the right, this is showing the breakdown on the frequency of the diagnoses. So the most common was immune complex mediated glomerular diseases, followed by diabetic nephropathy. But importantly in this study, HIVAM was still the number 3 most common cause of kidney disease diagnosed by kidney biopsy. And in reviewing the differences in the clinical features of kidney disease based off of this study, looking specifically at HIVAN, you can see that HIVAN patients, compared to the other types of kidney diseases, were about 10 years younger, and nearly all of them were self-reported Black race. There were less of them that were receiving antiretroviral therapy or adherent to therapy, and comparatively to the other kidney diseases, they had worse kidney function, so higher median creatinine levels and higher amounts of proteinuria. And if we compare that to FSGS, you can see here the age group was about 10 years older. 2/3 were self-reported Black race. The creatinine was lower though, but proteinuria was still nephrotic range. And if we look at all of these diseases and we look at the median urine protein to creatinine ratio, you can see that they all have several grams of proteinuria or nephrotic range proteinuria. So it's difficult, to tease out clinically which kidney disease somebody might have based off of these clinical features. So just a few practical points on the patient with HIV who presents with several grams of proteinuria. If they're young, of African ancestry, without other comorbidities, and they have a low CD4 and an unsuppressed viral load, the diagnosis is most likely HIVAN. But in everyone else, it's really difficult to differentiate the etiology or cause clinically. So I think any person with HIV who has heavy proteinuria and or declining kidney function, a kidney biopsy should be considered if it can be done safely and if we think it will alter their treatment course. And then what about antiretroviral therapy that may be associated with chronic kidney disease? So the double-edged sword of starting antiretroviral therapy right away is that it is lifelong and there is concern about potential kidney toxicity. The best data comes from the DAD study, which was a prospective international cohort study of people with HIV ages 16 on up. It was based in Europe, the United States, as well as Australia. And individuals in this study started with a GFR above 90. study. So there were almost 24,000 participants with a median GFR of 110 and a median age of 39. And participants were followed from baseline in 2004 until the first occurrence of chronic kidney disease. So over a median follow-up of about 7 years, 1% had developed incident CKD, and they found the medications that were associated with the development of incident CKD included cumulative exposure to tenofovir or TDF, ritonavir boosted atazanavir and ritonavir boosted lopinavir, as shown here, and this was after multivariable adjustment. So tenofovir, or TDF, is one of the most common ART medications that's associated with kidney toxicity. And this is because, as shown here in the picture, tenofovir gets secreted into the proximal tubule through these organic anion transporters. And here it can accumulate and ultimately lead to mitochondrial toxicity. So on kidney biopsy, this is characterized as an ATN, as shown here. These little pink areas are eosinophilic intracytoplasmic inclusions, which represent dysmorphic mitochondria or mitochondrial injury, as shown here on electron microscopy. And the clinical characteristics of TDF toxicity, it's characterized by acute kidney injury and signs of a proximal or type 2 RTA. So this can include having a low serum phosphorus and renal phosphate wasting, as well as low molecular weight proteinuria and glucosuria. In a clinical pathological case series of 13 cases of biopsy-proven TDF toxicity, after a mean of 1.5 years of exposure, 9 patients in the study presented with acute kidney injury and 4 had mild kidney injury with subnephrotic proteinuria. Glucosuria was also found in about 60% of patients, and 5 of them had no evidence of diabetes. Renal biopsy revealed toxic acute tubular necrosis. And after discontinuation of TDF, as shown here, the majority, you can see that there's a lot of reversibility, but the GFR may not fully recover. And in this particular series, 50% experienced complete recovery, but some were left with some permanent loss of kidney function. And risk factors for tenofovir toxicity include the use of boosted protease inhibitors, cobicistat, or ledapasvir, having a lower baseline GFR, as I'll show you, female sex, as well as low birth weight. And then what about non-HIV patients who are on pre-exposure prophylaxis or PrEP? So Truvada, which contains TDF, is a common oral regimen used for this purpose. And the PrEP and IPREX trials excluded individuals with pre-existing kidney disease. So there was a systematic review that was done, which included a longitudinal analysis of more than 14,000 PrEP users, where they found that 2.4% had a decrease in the creatinine clearance to less than 60. And in that systematic review, they identified that the biggest risk factors for declining GFR were age, as well as having a baseline GFR that was less than 90. Our current clinical practice guidelines don't support the use of PrEP if the baseline GFR, or don't support the use of PrEP with Truvada if the baseline GFR is less than 60. And it's also recommended to monitor kidney function twice a year in those at risk for kidney disease, so older individuals or those with risk factors such as diabetes or hypertension, whereas in everyone else, kidney function should be monitored annually. And then what about tenofovir alafenamide? So this is an alternative tenofovir prodrug that was first FDA approved for the treatment of HIV in 2015. And unlike TDF, TAF is not a substrate for the organic anion transporters in the proximal tubule. So it therefore doesn't accumulate there to the extent that TDF did. Concentrations in the blood are 90% lower, and it's been shown to have lower potential for both kidney and bone toxicity. And there are fixed dose combinations that have been approved for the treatment of HIV. And as a single agent, TAF is also approved for the treatment of hepatitis B. It isn't recommended to start if the baseline creatinine clearance is less than 30. And then what happens to GFR after switching from TDF to TAF? So there have been numerous switch studies have been done. This is one example of more than 3,500 participants, 2,400 of which were switched to TAF. On those who had a baseline GFR of 90, as shown here, there was really no change in GFR. So the green line represents the TAF group and the group that was switched to TAF, and the yellow line represents those who remained on TDF. But then if we look at those who have a GFR of 60 to 89, you can see that there was some improvement in GFR over 18 months in the group that was switched to TAF. But the most striking difference is in those with a baseline GFR of less than 60 or pre-existing chronic kidney disease. So the green line, again, is those in TAF. So those that were switched to TAF experienced about a 4-point improvement in GFR over 18 months, whereas those that remained on TDF continued to experience decline in kidney function of almost 6 points over that same period of time. In comparing the safety of TAF versus TDF, there's limited data on hard outcomes, and it's important to keep in mind that the majority of trials excluded patients with chronic kidney disease, so we really don't know if there's greater potential for toxicity in those individuals. But a pooled analysis of data from 26 randomized controlled trials of treatment naive as well as switch studies compared the incidence of proximal tubulopathy as well as discontinuation due to adverse kidney events. And they found that there were no cases of proximal tubulopathy in those who were taking TAF, and there were also fewer discontinuations for kidney events on TAF. And then what about TAF in patients who experience proximal tubulopathy, who were previously treated with TDF but had some degree of kidney injury? So this was a study of 31 people with HIV who previously experienced an adverse kidney outcome on TDF who were then given TAF. After follow-up of about 2 years in the study, which was mostly men as well as white individuals, after 2 years of TAF, there was no change in kidney function. There was no evidence of an RTA or any other biomarkers, changes in biomarkers of kidney function, suggesting that TAF is safe even in those with prior TDF nephrotoxicity. So just a few practical points about ART and those at risk for chronic kidney disease. It's not recommended to start TDF, atazanavir, or lopinavir based off of the data we have if the baseline GFR is less than 70, and it's important to risk stratify these individuals. So individuals that are going to be at higher risk of developing CKD are going to be those that have a lower baseline GFR, those that have proteinuria, older individuals, as well as those with coexisting comorbidities, including hepatitis, diabetes, and uncontrolled hypertension. And then in those that are on TDF, if the GFR falls to less than 60 while they're receiving it, it's recommended that they be changed to an alternative regimen. So I'm going to finish with discussing screening for as well as management of chronic kidney disease in people with HIV. So it's recommended that people with HIV be screened for kidney disease at the time of their HIV diagnosis and with ART initiation. This should be done using GFR estimating equations using the creatinine-based CKD epi equation. Proteinuria should also be assessed for, and this can either be done with a urinalysis or quantification with a urine protein to creatinine ratio. In terms of monitoring for CKD, this should be performed at least annually, but it depends on what the individual's risk is. And this should be done with GFR estimation as well as some assessment for proteinuria. And then referral to a kidney specialist or nephrologist should be considered in individuals who have unexplained AKI or CKD, those with a rapid decline in kidney function, new onset or worsening proteinuria, and in those who already have pre-existing kidney disease, if they're not being seen by a nephrologist, but their GFR is less than 45, they should be seen for delay of CKD progression. And in individuals with more advanced kidney disease, so GFR of 25 or less, they should be referred for dialysis preparation as well as a kidney transplant evaluation. Specific monitoring of kidney function is based off of CKD risk. So those lower risk individuals that are young with higher baseline GFRs and in the absence of comorbidities, kidney function should be checked yearly during follow-up if stable and virologically suppressed, as well as before and 1 month after any ART modification. And again, this should be done with GFR estimation and proteinuria assessment. In those that are at higher CKD risk, so older individuals with comorbidities, this should be done at least twice yearly during follow-up if stable and virologically suppressed, as well as again before and 1 month after ART modification. And then those that are on TDF, they're treated the same way as high-risk individuals. And in these individuals, you may also want to do additional testing to screen for signs of proximal tubule dysfunction. So this could include getting a serum phosphorus or checking a fractional excretion of phosphorus or urinalysis for glucose in those suspected to have or be developing a proximal tubulopathy. The frequency of monitoring of kidney function in people with HIV is based off of their CKD stage, which is based off of GFR level as shown here, as well as based off of the degree of albuminuria they have. So among individuals with very little proteinuria and very mild CKD or near normal GFR, they can be monitored annually, as I mentioned before, whereas as shown over here, individuals who have very heavy proteinuria and more advanced CKD, they need to be monitored at minimum 4 times a year. In terms of risk factors for CKD and underlying, in trying to determine the underlying etiology, this can be based off of, or this can include host genetic susceptibility risk factors, sociodemographics, other exposures and non-infectious comorbidities, HIV-related factors, as well as co-infections that can all contribute to the underlying CKD cause. So some that we've already discussed include the APOL1 genetic risk variants, sickle cell trait and other genes may also confer increased risk for kidney disease. In terms of sociodemographics, illicit drug use, so specifically cocaine or IV drug use, as well as other social determinants of health may be risk factors. For non-infectious comorbidities, diabetes, hypertension, cardiovascular disease. It's also important to ask about herbal medications, as well as non-steroidal anti-inflammatory agents, which many patients may take. HIV-related factors include, again, having unsuppressed HIV viral load and low CD4 count and specific ART medications. And then co-infection with hepatitis B or C have both been shown to be independent risk factors for developing CKD. And in specific parts of the world, other infections, including tuberculosis and parasitic infections, also can contribute. In terms of the management of CKD in people with HIV, the clinical guidelines for CKD prevention and treatment are really extrapolated from studies in the general population. Co-management with nephrology or a kidney specialist is important. And as I mentioned before, early referral to a nephrologist for CKD stage 3B or higher. So this correlates with a GFR less than 45 for the prevention of CKD, as well as advanced CKD planning. And then consideration for kidney transplant should be considered in those individuals who have well-controlled HIV. In terms of the co-management of CKD with nephrology, it's important to establish a diagnosis by identifying risk factors for kidney disease, quantification of proteinuria with urinalysis or urine albumin to creatinine ratio, and consideration for kidney biopsy if it could alter treatment. It's also important to recognize and treat complications of chronic kidney disease. So this includes electrolyte disturbances, specifically metabolic acidosis, can be associated with CKD progression. So this is something that needs to be treated, as well as other complications, including anemia or things like secondary hyperparathyroidism. And then there are specific strategies that can be used to try to help delay CKD progression. So some of the strategies to delay CKD progression in people with HIV include controlling CKD risk factors. So blood pressure control is very important, and there are varying guidelines on blood pressure targets in patients with chronic kidney disease. The majority of the world recommends targeting a blood pressure of less than 130/80 in people with chronic kidney disease. Our most updated KDIGO guidelines actually recommend targeting a standardized office systolic blood pressure of less than 120 based off of Sprint data in those who can tolerate it. It's also important to treat albuminuria. So in those that have more than 300 milligrams of albuminuria on quantification, they should be treated with either an ACE inhibitor or an angiotensin receptor blocker. And then in individuals who continue to have heavy proteinuria despite treatment with one of these agents, an SGLT2 inhibitor can be considered. It's important to counsel patients to avoid medications that could potentially be nephrotoxic, so NSAIDs, and then to avoid ART medications that also have nephrotoxic effects, such as TDF, or certain protease inhibitors, such as atazanavir, which has also been associated with CKD. In terms of specific treatments or targeted treatments, this depends on the underlying etiology. For instance, if a patient does have an immune-mediated glomerular disease, immunosuppression can be considered in a patient who's has well-controlled HIV and who is on stable ART. And in the last 10 years, kidney transplant has been performed in people with HIV, and overall, they've had good short and long-term outcomes. Data from a US cohort of more than 150 people with HIV who were transplanted reported 1 in 3 year recipient and allograft survival that was similar to the general population. It is important to note, though, that HIV kidney transplant patients do experience higher rates of acute rejection, and there are some significant drug-drug interactions with immunosuppression, including calcineurin inhibitors with certain antiretroviral medication classes. So it's important to consult with infectious disease and to avoid protease inhibitors as well as pharmacoenhancers, which can interact with some of these immunosuppressive medications. And pre-transplant is recommended if a patient already isn't on one to switch to an integrase inhibitor. In terms of HIV positive donor to HIV positive kidney transplantation, the best data for this comes from South Africa. So in the left here, this is a picture of Dr. Mueller in South Africa, who really pioneered the first HIV positive kidney transplant into an HIV positive patient in 2008. And later studies that came out in the early 2010s showed that HIV positive kidney transplant patients have similar outcomes to those without HIV. And in the United States in 2013, our Congress passed the HIV Organ Equity Act, which allows for the transplantation using organs from HIV positive donors into HIV positive recipients. And in this recent study, looking at the outcomes of HIV positive deceased donor to HIV positive recipient kidney transplants, this was a US pilot study of 75 HIV positive kidney transplants that occurred. 25 of the donors had HIV, whereas 50 were HIV negative. And as shown here on the right, the short-term outcomes, even up to 3 years, were the same, irrespective of the donor's HIV status. And in this study, they found no differences in 1-year graft survival, 1-year GFR, and there was also, importantly, no difference in HIV breakthrough infectious hospitalizations or opportunistic infections. And in 2019, a 35-year-old woman living with HIV in the United States became the first living HIV positive donor to provide a kidney transplant to an HIV positive recipient in the world. And I think this was a historic day that highlights that people with HIV can live long and healthy lives free of kidney disease and even be healthy enough to donate a kidney and save a life. And this will also allow for the expansion of the organ donor pool and has the potential to decrease wait times in HIV positive recipients. One concern after kidney transplant among people with HIV who previously had HIVAN is the potential for it to recur after kidney transplant. We know that HIV does infect the renal allograft, but in terms of HIVAN recurrence, in the US, this has been looked at in one study where they found that only 2 out of 150 patients with HIVAN had changes on biopsy, whereas in South Africa, about 25% had some histological features of HIVAN. However, in the study, no correlation can be found between the donor viral load and recurrence of HIVAN in this study. Importantly, although HIVAN changes were noted on biopsy, in most cases, this did not affect the functioning of the renal allograft. However, given the strong association between APOL1 risk variants and HIVAN, recipients of African descent and those who receive an allograft from a donor of African descent should be monitored for recurrent HIVAN. The contribution of donor and recipient APOL1 risk variants to HIVAN recurrence is the subject of ongoing research. The Apollo study is investigating the influence of these risk variants on long-term outcomes among both recipients and and donors of African descent. And some results are expected to be published later this year in 2023. And then finally, other ongoing areas of research in kidney transplant in people with HIV include whether or not HIV super infection recurs. We know that donor virus is detectable, at least short term, in kidney transplant recipients, but so far there's no evidence that this impacts outcomes. So just to summarize a few practical points on CKD management in people with HIV, it's important to monitor kidney function yearly in everyone, but more frequently in those with risk factors. And early referral to a kidney specialist for the evaluation of CKD etiology, treatment, and co-management of complications is important. ACE inhibitors or ARBs, with or without SGLT2 inhibitors, should be used in individuals with CKD who have proteinuria. And in those with more advanced chronic kidney disease, kidney transplantation can be considered in those who have well-controlled HIV infection, as the outcome, at least the short-term outcomes, have been shown to be excellent. And with that, thank you very much, and I'm happy to take any questions. Thank you.
¿Tendrá alguien alguna pregunta y respuesta para la doctora? ¿No? Bueno, le agradecemos, doctora Fisher, por su participación con nosotros en el GEVIHS Internacional 2023. Muchas gracias.